Welcome, everyone. My name is Kate Hawthorne. I'm with the Lankenau Heart Institute of Mainline Health, and I'm here today on behalf of the Women's Heart Initiative to discuss pregnancy and future cardiovascular risk. So hopefully you all are aware of the ongoing maternal mortality issues we're seeing, particularly in Black women in America. We know that Black women are 3 times as likely as white women to die from pregnancy-related complications. And obviously this is a huge problem that's going on. So the more we know about it, hopefully the more we can prevent. We do know that the leading cause of maternal mortality is heart disease and stroke. And so blood pressure is going to be something we're going to talk quite a bit about in the next few minutes. So when we think about women who go on to have these issues in pregnancy, there's really several different categories I want to think about. So during pregnancy itself, we can see high blood pressure. Those are called hypertensive disorders of pregnancy. And that can be really a whole spectrum of disease, from something called gestational hypertension, which is or used to be called pregnancy-induced hypertension. It goes by a few names, but really that's when a woman develops high blood pressure during pregnancy. And that's defined as blood pressure of systolic on top of greater than 140 or diastolic bottom number greater than 90. And generally that happens after 20 weeks of gestation. We are seeing that women are going into pregnancy with chronic or pre-existing hypertension. And so generally if a woman has high blood pressure before that 20-week mark, we think she falls more into that category. And then of course we have pre-eclampsia, which is high blood pressure, as well as some sign of end organ damage. And that can be symptoms like having a headache, that can be protein in the urine, that can be abnormalities within the liver or the kidneys, fluid on the lungs or pulmonary edema. So another whole spectrum of issues. And these women are much higher rates of going on to develop heart issues or stroke. So this is a major category to monitor very closely. Gestational diabetes, or developing diabetes during pregnancy, is another major risk factor. And then we think about a woman's future risk of cardiovascular disease. We know that even a delivery at preterm increases her risk, and we're not really quite sure why currently, but hopefully we'll be figuring that out over the next few years. So there's preterm birth before 37 weeks gestation, and then early preterm or delivery of a baby before 34 weeks is an even higher risk factor. And then pregnancy loss, as well as intrauterine growth restriction or having small babies, is another risk factor. So we do know that the rates of hypertensive issues with pregnancy are on the rise. And if you look at the orange bar over on the right side of the screen, that's since 1993 to 2014. And you can see that that orange line has really increased over time. So we're seeing the rates of high blood pressure issues increase. What's even more alarming is we know that the rates of preeclampsia and eclampsia and even more severe development is higher for African-American women, 61% compared to other white counterparts. And that's from old data. And so those numbers may even be, unfortunately, more discordant. And so again, this is something to make sure that we're aware of during pregnancy is a major risk factor for issues during that pregnancy itself, both for mom and baby. And we think about those adverse pregnancy outcomes, or APO for short, we know that they go on to increase a woman's future cardiovascular disease. And if you walk away with nothing else today, I hope that you acknowledge those risk factors and think about that time period as a unique opportunity. So I truly believe if we can start addressing these pregnancy outcomes, we can improve a woman's future cardiovascular risk by addressing those risk factors early and aggressively, and making sure that we decrease her future risk. So again, those are some of the adverse pregnancy outcomes that we talked about, and things to make sure we're keeping in mind when we develop a plan for a woman's risk factor profile. Unfortunately, there's both disparities during pregnancy and even during cardiovascular care. So this is a busy slide, but when we think about women in general, we know that women are inadequately treated for cardiovascular risk factors. If you take a woman versus a man is more likely to be treated for high blood pressure and high cholesterol alone, 2 major risk factors for heart disease. If you look at Black women specifically, those disparities are even bigger. And if you look at young Black women, an even bigger gap in disparities. So again, this is certainly an area that we should be thinking about attacking to help narrow those disparities. Despite even more cardiovascular risk factors, we know that Hispanic women and Black women have less effort on secondary prevention. And again, so that's looking at those risk factors and making sure we treat them. The rates of lipid lowering medications, cholesterol medicine, even counseling for smoking is lower amongst non-white women. So again, we have major ground to cover, and there's certainly disparities that we need to address. And I think one of the most important things is being a patient advocate, being aware of these disparities, being aware of your risk, knowing that those pregnancy outcomes increase risk and that you should be treated more aggressively for blood pressure, cholesterol, of course, smoking. This is a really great infographic that comes out of the California Maternal Quality Care Collaborative. And it's just a reminder for women. I give it out to a lot of my patients in thinking about those risk factors for cardiovascular disease and some things to think about. When we look at patients who come in with their first heart attack, we know that many of them had untreated risk factors. And so this is just a slide looking at that and looking at men versus women. But again, we know that many patients who come in already have high blood pressure, high cholesterol, obesity, all of which was untreated. And so again, it's important that we think about these risk factors early and treat aggressively. This is a slide that comes from the American College of Cardiology and thinking about primary prevention. And really, lifestyle goes a long way. So if you look at all the pieces to the puzzle, lifestyle is a big part. We've got diet, making sure we're increasing our intake of fruits, vegetables, nuts, legumes, fish, and whole grains, minimizing processed foods, physical activity. We recommend that patients perform more than 150 minutes per week of regular aerobic exercise. Quit smoking. So tobacco use, vaping significantly increase a person's cardiovascular risk. And then cholesterol, addressing a patient's risk, thinking about those risk factors that maybe aren't the classic ones that are on all of our risk factor tools and treating as we need to. High blood pressure. So from a cardiology standpoint, we recommend blood pressure less than 130 on top, 80 on bottom, which is a little bit more aggressive, but we know that outcomes are improved if we target blood pressure. Controlling diabetes or blood sugar. And a lot of that can be through lifestyle and then medications when we need to. Thinking about using aspirin in appropriate patients. There's been some changes in the guidelines, but there's still plenty of patients who it's appropriate therapy for. So really, there's a lot that we can do to prevent our own cardiovascular future and improve our risk of having a cardiovascular event. So that's all. I just wanted to thank you for your time. Of course, if there's any questions, we're always happy to help. We've got some great resources through the Women's Heart Initiative. So please reach out and take a look.